My name is Gillian Rosenberg. I'm the Senior Scientist in the Haematology Department at the Prince of Wales Hospital, Sydney, Australia, and my specialty is blood film morphology. So I'm going to take you through a series of workshops that I have prepared, going through red cells, white cells, and platelets, and also pediatrics. So we'll start off with red cell nomenclature. So red cell nomenclature is divided into two parts. Part one will show you the various shapes of the red cells and also the nomenclature which should be used to describe these red cells. The red cell nomenclature comes from the guidelines produced by the ICSH, which is the International Council for Standardization of Hematology, which you can find online. And the second part will list the clinical conditions associated with the particular red cells described in part one. So the morphological abnormalities seen in the red cell offer a key to the interpretation of a particular pathological condition. Conversely, certain pathological conditions are attributed to the presence of particular red cell shapes. With this in mind, the morphologist must be ever mindful of the standard nomenclature used to describe such red cell shapes. So we'll start off with normal red cells. So normal red cells are biconcave discs or discocytes, and they have a mean diameter of 7 microns, and they're approximately the size of a small lymphocyte nucleus. The red cell membrane is very elastic and deformable, readily able to reassume its discoidal shape after cessation of a deforming force. The images that I'm going to show you are all taken under 100 oil immersion, so the magnification is actually 1,000 times. And these were all taken by myself, none of these coming from the internet. So this just shows you normal red cells. Biconcave discs, and they have an area of central pallor, which you can see normally in normally forming red cells. So I'm also including the electron microscopic images of red cells, and these images all come from a book which was compiled by a French author called Marcel Bessy. And the book was produced in 1975, and it's a very beautiful book that just gives you the electron microscopic picture of red cells and how they look. It makes it much more easy to correlate the electron microscopic picture with the picture that's been taken, or the image that's been taken under the light microscope. So microcytes. Microcytes are red cells with diminished diameter, less than 6 microns, and they have a diminished thickness. The hemoglobin concentration of microcytes is reduced and often concentrated in a peripheral ring, while the center is pale. This pale center may be so increased in size that the cell resembles a elliptocyte, or a thin, flattened red cell. Microcytes are a characteristic feature of iron deficiency and thalassemia. So this is showing you the microcytes, and I've put in the center of this image a small lymphocyte, and the nucleus is 7 microns in diameter, so you can compare the size of the red cells with that nucleus. These cells are all microcytic and small, so the MCV will be low. The normal range for MCV is 80 to 100 femtoliters. Keep that in mind when you're looking at your blood films. So macrocytes, round macrocytes, they're red cells with an increased diameter, more than 8 microns. They maintain a normal discoid shape, and they have a well-defined central depression. Round macrocytes are a characteristic feature of alcoholism and liver disease. And this is a nice film showing you that this patient is somewhat anemic, but these are round macrocytes. Oval macrocytes. Oval macrocytes are giant-sized red cells with a diameter of more than 9 microns. Oval macrocytes are a characteristic feature of megaloblastic anemia. This patient is clearly anemic, and the cells are quite large, and you can see when you look at some of these classically oval-shaped cells, that's a feature of megaloblastic anemia. So target cells. Target cells are bell-shaped, thin-walled cells that have an increased surface area compared to volume. This is the result of red cell membrane expansion by the accumulation of lecithin and cholesterol from free exchange with plasma lipids. The term target describes the appearance of these cells when dried on a glass slide. They have a characteristic distribution of hemoglobin in the center of the cell, as well as around the periphery, with the two regions being separated by a pale ring. Target cells are associated with liver disease, with thalassemia, hyposplenism, and some abnormal hemoglobins. So this is a nice slide showing you target cells. These are classic target cells here. Sometimes you may get an artifact which some scientists may describe as being a target cell, so you need to be very careful when you're doing this. For example, should you be working in a laboratory, perhaps where it's not air conditioned and you're making your films manually in a cabinet? If you don't dry those slides or those cells on the blood film really quickly, you will get an artifact. Now, this is a really good slide, but this, if you had a slide like this where you had like a semicircle of this hypochromic area, that can be produced by absorption of moisture from the atmosphere onto the red cell. So you need to be very careful, dry your slides immediately once you spread the blood film, and your target should have this 360-degree area of hyperchromia. So here we have the electron microscopic picture of the target cell. So when you spread your film, this part here will come down into the center. So that's the central area, which is fully hemoglobinized. And then the space here will be your 360 degrees of hypochromasia. And then this outside rim of the red cell will be the outside rim, which is fully hemoglobinized. It's really, really important to remember one thing that you may not find in many textbooks, and that is that the surface area compared to volume is increased in target cells. So that means if you've got moderate numbers of target cells on a blood film, that will actually reduce your mean cell volume. And you may have a film where you've got moderate target cells with an MCV perhaps of 56, keeping in mind the range is 80 to 100. So 56 ventiliters, you'd expect to see lots of microcytes. But if you've got lots of moderate to marked target cells, that is the reason for that low MCV, not because there are microcytes there. Very important to remember that. So elliptocytes. Elliptocytes are oval-shaped biconcave discs that vary in shape from being slightly oval to cylindrically shaped. They have both a quantitative and a qualitative abnormality in two major proteins comprising the membrane skeleton, namely spectrin and protein 4.1. Whilst approximately 5% of elliptocytes can be seen on normal blood films, between 30 and 100% are seen on blood films in patients who have got hereditary elliptocytosis. Elliptocytes are also a feature of iron deficiency, but in this case without spectrum or protein 4.1 abnormality. And this is a beautiful film of somebody who has got hereditary elliptocytosis. You can see all of the cells are elliptical, and just note that the ends of the red cells are rounded. In many cases, these particular patients with hereditary elliptocytosis have completely normal red cell parameters and will be auto-validated by your analyzer. So you may not see so many cases of hereditary elliptocytosis. And here's the electron microscope picture showing you that this is indeed a biconcave disc, but this is how it looks under the electron microscope. So now stomatocytes. Stomatocytes are bowl-shaped red cells which exhibit a slit-like area of central pallor. Stomatocytes are associated with alcoholism and also a feature of two conditions, namely hereditary stomatocytosis and Southeast Asian ovalocytosis. In each of these conditions, the membrane defect is different. In hereditary stomatocytosis, there is a deficiency of protein 7.2b or stomatin in the red cell membrane. This deficiency leads to an influx of sodium into the red cell and a loss of potassium exiting the red cell. Hence, the red cell swells and they're transformed from discocytes to bowl forms. They have a high mean cell volume, usually about 130 and can go to 150 femtoliters. So this is an example of the very, very rare case of hereditary stomatocytosis. You can see that they have a single slit. Now, I just want to explain this one to you because this particular disorder, there are only about 5 cases in the world with this disorder. When I got this film, this came from the son of the first Englishman who was diagnosed with this disorder in the UK. And he brought to the hospital his results from a very old-fashioned analyzer called the Technicon. He brought the documents of the literature that had been written up on his disorder. And when I passed this to a red cell expert in Sydney, he told me that there are only about 5 cases with this disorder in the world. So you probably will never see this again, but it's very useful for you to know that it does exist and what it looks like. So this is hereditary stomatocytosis. You can see this is part of the discocyte and this is the bowl form. The base of the cell is not like a disc, it's the bowl form, and that's because you've got more sodium going into the red cell than potassium exiting it. So it's almost like you've got a waterlogged red cell. If you think of it that way, it makes sense. So in Southeast Asian ovalocytosis, there's an increased ankyrin binding and decreased protein 3 mobility, leading to the production of very rigid red cells. These red cells are oval in shape. They often have double transverse slits, and they have a normal mean cell volume. Stomatocytes may occur as an artifact, so that's something to be mindful of. And when it does, it's usually in the presence of improper physico-chemical conditions occurring in vitro. So here are the classical stomatocytes of Southeast Asian ovalocytosis. You need to look for the 2 slits, and sometimes the slits are V-shaped. So 2 slits here, classically found in Southeast Asian ovalocytosis. And this describes it beautifully to show you the stomatocytes with the 2 slits. So these cells are really very rigid, and one of the good things about these cells is it's called Southeast Asian, that these cells do reduce the amount of malaria entering, or the malarial parasites entering into the red cells. So it's a protective agent in the Southeast Asian area. So spherocytes. Spherocytes are red cells that are almost spherical in shape. They are no longer biconcave discs. They appear as slightly smaller, hyperchromic red cells with little or no area of central pallor. And the mean cell volume of spherocytes is in the normal range. So I've said that they appear slightly smaller because spherocytes, being abnormal cells, are removed by the spleen, and therefore you may get an increase in reticulocytes to compensate. So as you know, the reticulocytes have a slightly larger diameter. So when you've got a larger reticulocyte and a smaller spherocyte, you're going to end up with a normal mean cell volume. So they compensate for each other. Spherocytes are a characteristic feature of hereditary spherocytosis and autoimmune hemolytic anemia. The spherocytes of hereditary spherocytosis are attributable to an intracorpuscular red cell membrane defect. So there's a deficiency of spectrin, ankyrin, or band 3 protein, and this leads to the uncoupling of the skeletal lipid bilayer, resulting in membrane loss in the form of microvesicles. On the contrary, spherocytes of autoimmune hemolytic anemia are the end result of coating of red cells with immunoglobulin, namely IgG and/or complement proteins. And here's a lovely film to show you two types of cells. Here you can see the reticulocytes, which are larger, slightly larger, and we call them polychromatic red cells because they stain a slightly mauve color with the Romanowski stain, and the spherocytes, which are smaller and very hyperchromic, no area of central pallor, and they stand out clearly as being abnormal. And of course, when you compare the diameter of this cell and this one, the two compensate to give you usually a normal mean cell volume. Here is the spherocyte, a round ball, so to speak, very hyperchromic with no area of central pallor. Sickle cells. Sickle cells are biconcave discs that, upon deoxygenation, they change shape to become crescent or sickle-shaped. They have an abnormal hemoglobin S, which is produced by the replacement of glutamic acid with valine at the 6th position on the beta chain. Sickle cells are deformed by the precipitation of polymerized hemoglobin S. They appear as sickle or crescent-shaped red cells on the blood film. As well as being a characteristic feature of sickle cell disease, sickle cells are also a feature of double heterozygote disorders that include hemoglobin S. This is a light microscopic film of the sickle cells, and see how they're not like the elliptocytes with rounded ends, they have pointed ends. Sometimes they will change shape and become sickle-shaped when they become deoxygenated. Now, for those of you who are astute, some of these sickle cells have got a Hal Jolly body in the red cell. So, for example, when these sickle cells get into the fine capillaries of the body, namely into the spleen, and they become deoxygenated, they change shape and actually block off the blood supply to the spleen. So you get, for want of a better term, you get splenic infarcts occurring in the spleen. And if you get hyposplenism, for example, which is the result of the splenic infarcts, you can get features of autosplenectomy, one of which is Hal Jolly bodies. So that's why you see Hal Jolly bodies in the red cells. And here's the classical, beautiful sickle cell under the electron microscope. Teardrops. Teardrop-shaped red cells are characterized by a single elongated or pointed extremity. They are a characteristic feature of a leukoerythroblastic disorder, such as myelofibrosis and also metastatic carcinoma. So anything that's infiltrating the bone marrow can give you a leukoerythroblastic blood picture. Teardrops are also present in thalassemia and in megaloblastic anemia. And this is in fact a film of somebody with myelofibrosis. I haven't included the white cells in this case, just to show you the teardrop-shaped red cells. These are the teardrops that I'm pointing to. And here's the teardrop red cell under the electron microscope. Acanthocytes. Acanthocytes are round, hypochromic red cells with several fine spine-like projections spaced unevenly over the entire surface. Acanthocytes are a characteristic feature of hyposplenism, splenectomy, A-beta lipoproteinemia, and the McLeod phenotype. A-beta lipoproteinemia is a disorder occurring specifically in young children. So this is a case of a patient who has had a splenectomy and has got a lot of acanthocytes in the blood film. So you're looking at those cells which look almost like a spherocyte in that they don't have an area of central pallor. I put some in the center of the field to show you. No area of central pallor. They have these fine spines protruding at irregular intervals. And this is the acanthocyte under the electron microscope. So you can see it's almost like a spherocyte, but it has these fine spines projecting at irregular intervals. Bite cells and blister cells. Bite cells are found when Heinz bodies, the product of oxidant stress on the hemoglobin molecule, together with some red cell content, are removed from the red cells as they pass through the spleen. When the red cell membrane around the bite repairs, a blister-like structure forms, hence the term blister cells. Bite and blister cells are a characteristic feature of oxidant hemolysis, seen in subjects with normal and reduced levels of glucose 6-phosphate dehydrogenase. They appear or may appear after the administration of, these are the oxidant drugs which we most commonly come in contact with when we're looking at blood film morphology. So dapsone, you should know these in the back of your mind. Dapsone, salazapirine, Bactrim, which is the antibiotic, is an oxidant. Some of the antimalarial drugs are oxidants, for example, primaquine and chloroquine. Never forget that the fava beans, which are broad beans, can act as an oxidant. So this is a blood film showing you oxidant hemolysis, really showing you two types of cells here, showing you the bite cells, which will look as if they're red cells, which appear to be slightly hypochromic with almost chunks taken out of them. So they're not completely rounded, chunks taken out of them. So as these cells pass through the spleen, then the Heinz bodies are removed. Of course, you cannot see the Heinz bodies with the Romanowsky stain. So you may choose to do a Heinz body stain. I would personally not do that because the only stain that stains Heinz bodies is the supervisal stain, namely methyl violet. And when you do that methyl violet stain, it's not a very nice stain. It's not nice and clear. So the fact is that I think if you see the bite cells and the blister cells, then you've got a classical picture of oxidant hemolysis. Now this red cell here, if you look at it carefully, you can see that some of the red cell content has been pulled out together with the Heinz body, okay? And here we've got a blister cell. So when this red cell membrane, which has lost some content of the red cell, lost the Heinz body, when that red cell membrane is joined back up, you get a blister cell. So the two cells in combination are features of oxidant hemolysis. So something that you won't read in a textbook, and I think you should actually take notice of what I'm going to say. I think some people are a little bit suspicious that I'm not correct. But if you take this particular blister cell, and if you look at this cell here, which is very hypochromic, because it's lost some content, lost the Heinz body, if this red cell landed upside down on the glass slide, you would just see this area here, and it would look like a spherocyte. This cell here as well, landing upside down on the blood film, the glass slide, would look like a spherocyte. I would not comment on spherocytes. They do not have the membrane defect that is seen in spherocytes, and I would not comment on them. I would not call them spherocytes because spherocytes are not a feature of oxidant hemolysis. This is a fact which is actually little known and little recognized. Now, when Marcel Bessy took all his photographs, I don't think it was known about bite cells and oxidant hemolysis. This image actually doesn't come from his book. It comes from another author, and an author in hematology pediatrics from Queensland in Australia. But this clearly shows you a beautiful picture of a blister cell. So it demonstrates to you that there's a space here where the Heinz body has been pitted out, where the content of the red cell also has been removed, so you've got a space, and then the red cell membrane has joined back up. You get a blister cell. And interestingly enough, you don't often see as many blister cells as you see as bite cells on the blood film. So schistocytes. As you've noticed, and I haven't read it out to you, but you've got the Greek derivation of all the red cell shapes. This is something that's so important, and so people get this so wrong when they're reporting on blood films. A schistocyte comes from the Greek word ski, which means to rip. Never forget that. So schistocytes, they're sharp, pointed, fragmented cells produced by a microangiopathic process. And it's important to understand microangiopathic stands for micro, stands for small, angio for vessel, and pathic for disease. So red cells are fractured or ripped as they pass across strands of fibrin in damaged vessels. For example, in hemolytic uremic syndrome, or as they pass across a damaged or a prosthetic heart valve. This is a case of schistocytes. Actually, I think in a case of a young child that had heart valve problems. And here you see these are classically schistocytes. So you should not call them fragments because they've been produced by a completely different process, and I'll explain fragments when I talk to you in the second part of this red cell section. These have been shredded and ripped as they pass through a narrow vessel. The only term to describe this is schistocytes. And here's the schistocyte from Marcel Bessy again, back to his images. Classical schistocyte seen on the blood film. Crenated cells. Crenated cells are red cells with irregularly placed projections on their surface. They are invariably present as an artifact that develops if blood is allowed to stand for a prolonged period of time at 20 degrees C prior to the blood films being made. Crenated cells present in freshly made blood films may be a feature of renal disease. I thought that this was also the second sentence, which I would think you should probably disregard, but they thought to be occasionally present in young children who have got severe gastroenteritis and are severely dehydrated. But that may not be 100% correct. So this is a beautiful blood film of a patient with lots of crenated cells. So I'll tell you how I made this film. This blood came into the laboratory at about 5 o'clock in the evening, and it was a normal blood film. Red cells were normal. So I was trying to work out how to get a nice film of crenated cells for these workshops. So I left this blood out of the fridge at night, and the next day, around about 9 o'clock in the morning, it was left on the bench in the hematology laboratory. I made another blood film. And so this is old blood, which is showing you what you get when you've got old blood and crenated red cells. So they have an even frill around them. So crenated cells, when you see them, do not report them. They are an artifact. And if you've got lots of crenated cells, perhaps you need to look at the age of the sample when it was collected. You may find that it was collected the day before. Do not report on it. And here's a crenated cell. So Burr cells. Burr cells are red cells with varying numbers of spines occurring at irregular intervals on the red cell membrane. Burr cells are produced as a result of damaged glomeruli in severe glomerulonephritis and in acute renal failure. And I'm just emphasizing acute renal failure. They're not usually a feature of chronic renal failure. And this is a nice example to show you there are some crenated cells, which I'm not commenting on, but this cell here, and this cell here, and this cell here are classically Burr cells. Now the ICSH nomenclature calls these Acanthocytes, and the ICSH nomenclature came out long after Burr cells was a recognized terminology. So it's up to you how you want to report these cells. What you should do is look at the renal function, look into the chemistry results and see what the urea and creatinine are. If they're raised and the patient's got acute renal failure, I personally would call them Burr cells. If you want to use Acanthocytes, you can use that term, but it won't make it very clear to the consultant what you're describing. And here's a classical Burr cell, almost identical to the cells I pointed out to you on the blood film. Spur cells. Spur cells are spiculated red cells with equally spaced short spines over the entire surface of the red cell. They appear as three-dimensional on the blood film. Spur cells are the product of two stages, produced in two stages. So firstly, excess cholesterol produced by the diseased liver increases the surface area of the red cell membrane, resulting in a red cell with a scalloped or an undulating periphery. Secondly, these scalloped red cells are converted to Spur cells by a process of splenic conditioning. Over a period of a few days, the membrane lipids, as well as the increased surface area, are lost, and the red cell becomes rigid, assuming the appearance of a Spur cell. Spur cells are a characteristic feature of fulminant hepatocellular disease. This hematological condition is commonly referred to as Spur cell anemia. Now this film, I apologize, is not completely representative of the Spur cell. It is very difficult to get a nice image of a Spur cell. In the second part of this red cell section, I've got a beautiful image to show you. So this isn't so good. These perhaps can look like Acanthocytes. So take not too much notice of this image. But if you look at the electron microscopic picture, it makes it very clear that they are three-dimensional They've got these spines coming out from all directions, three-dimensional. That's a classical spur cell. So the art of morphology involves the correlation of red cell changes with the parameters issued by the blood cell analyzer. The shape and size of the red cells should relate to the age of the patient and also to the clinical condition of the patient. Once a particular red cell shape has been observed, the morphologist should scan the film for further red cell shapes and inclusions which may be linked and together be indicative of a clinical disorder. So you can see, I believe that we are diagnostic morphologists. We're not just morphologists that report on what we see and don't understand what we see and why it's there. And this is the exciting part of blood film morphology. I thought I might not say this on this PowerPoint presentation, but I'm just going to say this because I think it leaves a bit of an impact on you. There used to be an ad on the television about a particular dress shop, and it used to say, this goes with that at the particular dress shop. And it's basically what morphology is about. So you can mix and match according to the tops or the skirts, whatever you wear from this particular dress shop. And so like it's the same thing in blood film morphology. You see one feature and then you know, so perhaps you see a target cell. And so you say to yourself, okay, so target cells are a feature of thalassemia. Are there microcytic red cells on the film? It's a feature of liver disease. Are there macrocytes on the blood film? And so on. And this is really the art of morphology. So the following conditions are associated with specific red cell shapes and sizes. So the art of morphology is being able to recognize these red cell shapes and changes and suggest the relevant tests to make a diagnosis. So this is the end of part 1. So part 2, we're going to describe different disease states associated with these red cell shapes.